Ladies and gentlemen, good evening. My name is Julia Clark. I'm the Director of Public Participation here at sath, which covers community engagement, volunteers and sath charity. And I'm delighted to welcome so many of you here tonight to what is the first event in a programme of engagement events that we'll be organising around the development of the HTP agreed clinical model. As I said, this is the first in a series of events that we'll be arranging, and you'll hear more about that tonight in the presentation, in which we'll be updating you on where we are and briefly how we got here, and then on the next steps and how you can get involved or how you can get more information. We've had an amazing response to the event, with over 160 people registering for the event, which is great, but due to the numbers, we decided it would be better managed as a live stream. We will record the live the presentation and the speakers as well, and it will be made available on our website, and everybody that's on the meeting tonight, we will send you a link through when we've uploaded it. Because of the sheer number of people that had registered, we asked for questions in advance, and a dozen people have sent through questions, very common themes, and hopefully, if we've got some time at the end of the presentation, we'll go through the main ones, but we will be answering every individual questioner with a response, and we will be posting these and any other questions that we receive on our website. So for complete transparency, it will be visible to everybody. As we're very tight on time, I'm now going to hand over to Nigel Lee, who's our Director of Strategy and Partnerships, and he's also the Senior Responsible Officer of our Hospital Transformation Programme, who will introduce the rest of tonight's panel to you. Over to you, Nigel.
Thank you, and good evening. And as Julia said, we're delighted that lots of people have joined us this evening. With me this evening in the room is Dr. Ed Rysdale.
Good evening.
Hello.
I'm an emergency medicine consultant and the clinical lead for the Hospital Transformation Programme.
Richard.
Richard Sean. I'm a chest surgeon by background. I'm medical director for strategy and partnerships.
And Jenny.
Hi, I'm Jenny Follard and I'm the Chief Communications Officer.
Thank you. So, and as Julia said, between us, what we'll do is we'll run through the key steps, some key information which we hope will be of value to everybody, and outline what our programme of events is over the next few weeks and months. So if we go to the next slide, if I may, please. So we wanted to start with just a quick update on some of the journey that we've been through and the progress and all the key steps. And I think it's really important that this has been a rigorous process as we've gone through the review of the strategy and the model of care. We know that the Future Fit programme was set up some years ago, and it's important that that's been rigorously reviewed. Back in 2016, the clinical strategy and model of care was agreed, and this was followed by the important public consultation in 2018. The CCGs agreed that clinical strategy and model of care in early 2019, and that was also independently reviewed by the Independent Reconfiguration Panel, which is a national panel, which also confirmed that the new model should be implemented. We then, of course, have, like everybody else, have been impacted by COVID from 2020 for some time, but we've been able to restart the programme as soon as we're able to with the national colleagues. And in August of last year, we had the approval of the strategic outline case. And I think, you were going to just, you've been involved in the process, Ed, throughout a lot of this, haven't you? So you were just going to reiterate.
Yes, I've been involved both when I was working over in Stoke-on-Trent as a consultant and then coming back to Shrewsbury and Telford 4 years ago. So I've been involved in the process for a long time, and it seems like it's been going on a long time, and it really needs to move on, and we need to get this delivered now, because the likes of myself have come back for this, and we'll go through this in the coming presentation. There has been a 2-year delay, which was unexpected and unavoidable due to the pandemic, but we are moving forward now, and it needs to continue with the pace that we've got going.
And I think throughout this, and hence why Richard and Ed have joined me tonight, this has been clinically led from the outset, and it's really important that remains so. The next phase, which we're already in, is developing on what's called the outline business case, and a heck of a lot of detail that we're working through with our clinical teams, and then supported by architects and others. We expect to submit that outline business case in the summer of this year, and then move on to the development and the submission of the full business case in the autumn. The plan of action is that by the end of this calendar year, we'll then be able to start the implementation. And I think importantly, throughout all of this, we will continue both with our staff, with our patients and our communities to continue to involve and help the design and the detail of the different pathways of work.
I think that's really, really key as well. So with the design of the outline business case, our clinicians are front and centre. We're going out to all of the relevant clinical bodies and clinical groups, both locally and nationally, and we are having real clinical involvement. This is very much a clinically led process to deliver the care that we need to for the county and Mid Wales.
And I think it's important to note that we've also had that support from key national clinical bodies, haven't we, in terms of the clinical model of care?
Yes, and I've reached out to my college and the College of Emergency Medicine, and we've spoken to the national leads for urgent emergency care. So we have sought advice and support from national bodies,
which they've absolutely endorsed. I think if we move on to the next slide, then we've obviously described a lot of this in our strategic outline case, and a number of people across our communities will have heard this. But with COVID, then it's emphasised even more that we need to look at how we design the model of care and improve that for the benefit of everybody. We're absolutely committed to developing and improving 2 thriving hospital sites. And that's all about improving the quality of care, the waiting times, the diagnosis, and optimising the hospital stay and the recovery. And I think this is importantly, it's about this investment being for the benefit of everybody. We provide services across Shropshire, Telford and Wrekin and Mid Wales, and that's really, really important to us. I think the other bit is that we know that we've got duplicated services across different sites, and some services on one site for another. And Ed and Richard will talk a little bit more about that as we go forward this evening. That means that we've got unsustainable workforce issues across a number of those, and contributing to the long waiting times, especially for planned care. And we know we've also got some estate which doesn't give quite the layout and space and capacity that we need, especially in some of our important services such as critical care, and that is a key part of our investment. And we are absolutely focused on making sure that we look at all of these issues for the benefit of patients and outcomes. Thank you. I think the other bit that's really, really important to us is how we work as part of an integrated care system. Our colleagues in the ICS, as well as in our community services, in primary care with our GPs, with our local authorities and the council and social care teams, as well as the voluntary sector. This is really, really important that the hospital's transformation programme is important, but it's only one part of the improvements in care that everybody is working towards. And we're really, it's a really important element that we're really, really focused on. And we know that others across our health and care communities are of the same view. Thank you. I think the final one for me before I pass on to my clinical colleagues is this is, again, as I've mentioned, we're really keen to make the progress with improving the model that was been through the consultation, that independent review, and has had the approvals. We absolutely are continuing to design the detail, and that's why, as Julia mentioned, with the support of Jenny and her team, we're absolutely keen to make sure that we continue to involve patients, our staff, the wider community, and other experts in making sure that we're absolutely optimising the services we provide. Ed.
Okay. So the momentum is absolutely key, and we need to keep this going. So I'm just going to describe a bit about what's going to be happening and where facilities will be. So there'll be urgent care centres of 24 hours a day at both sites. And that's really important. There's been a lot of talk about emergency services and the A&E moving. The vast majority of our patients require urgent care and don't actually require services of an emergency department. But the dedicated emergency department will be at the Royal Shrewsbury site. And that'll actually mean that everybody will have faster access to the medical and surgical specialties that they require. The emergency department is just one small part in delivering care for the life and limb threatening emergencies that come through our departments. At both sites, as I say, there'll be 24-hour urgent care services. And so the majority of patients who are seen and treated in the same day will continue to have that care close to where they live. The dedicated facility for planned care at the PRH site, again, is vital, as we've seen over the last couple of years. Planned care is key to the vast majority of patients who receive care in our hospitals are on a planned procedure, on a planned pathway. So ring fencing that, making sure it happens, is absolutely vital for providing the best care for our patients. The investment we've got is significant, and this is important because we'll have 2 thriving hospital sites. It's really important for us, if we're going to deliver the best care for Shropshire and Mid Wales, we have to have 2 thriving hospitals, doing different things, but both thriving. It means it'll be a really good place to work. It's one of the reasons I've come back to Shropshire. It'll be resilient to seasonal pressures and the potential future pressures that we've seen in the last couple of years, and that's quite key. And how we've looked at things has changed and moulded, and will continue to mould the process. We have the clinical model set. How we implement it is being developed as we go, and that's one of the reasons we're here, to have the conversations with our patients and with our staff to work out how we deliver the best care that we can with the clinical model that we are developing. So this is one part of a wider ambition to improve health and care for everybody. It is absolutely key that we deliver the best care for everyone that we can look after. And I said the most important thing, that this is being clinically driven by our clinical teams in both hospitals. So this is a quick slide showing as an infographic of what we've got. So both sides will have 24-hour urgent care centres, as I've said. There'll be diagnostics at both sites with outpatients for adults and children at both sites, midwife-led maternity services, frail and elderly services, and there'll be diagnostic endoscopy, so scopes at both sites, and day case chemotherapy, which is new to the Telford site. They don't currently have that, and that's a new addition to the Telford site. So that's really key, and that is the vast majority of care that is delivered to our current patients will continue to be delivered at both sites. At Telford, they'll have the specialising in the planned care site. So this is the planned elective surgery procedures and the day case surgery, and surgical procedures that don't require the critical care services, which will be located at the Royal Shrewsbury site. There's the A&E local model with the enhanced urgent treatment centres, and this is far more than just a GP-led urgent treatment centre or minor injuries unit that we've had elsewhere in the county. This will have increased diagnostics with a acute medical service alongside it for same-day care. So if you can be seen and sorted in the same day, you'll continue to have the care at the Princess Royal site. There'll be inpatient medical care for patients on a planned pathway of care. So if you've been into the Royal Shrewsbury as an acute admission and you need longer care, you'll be transferred over to the Princess Royal for a planned care of inpatient medical care. And then there are lots of different surgical specialties that will have their planned operations delivered at the Telford site. At the Royal Shrewsbury site, we're specialising in emergency care. And this is key because it brings all of our specialist emergency services together. So that's acute medicine, our critical care unit, our acute surgical units, our children's units, and our women's delivery units. Being all on one site means that we can deliver faster care to our patients, so we can get the right patients to the right specialties quickly. And as I said, the children's unit, the CAU, will be relocated over to Royal Shrewsbury to bring it in line.
I think a key point with emergency care is often it needs more than one specialty. And a lady coming in pregnant with a severe stomach pain, it could be the labour, it could be all to do with obstetrics, but it could be a general surgery issue. And what we want is to make sure that whatever the issue is, the right specialty is immediately available. And what we want to avoid, and this is a key part of the clinical model, is that the specialists you didn't expect to need are on the wrong side when you most need them.
Next slide, please. So we want to provide excellent care in the right place at the right time from the right people, just as Richard was saying. So the dedicated emergency department with immediate access to all of our medical and surgical specialties. So this is timely access to the right specialists, and that's really key. And we've shown over the last few years with our major trauma service and our cardiology service in Stoke that actually the distance to getting to the right patient is less important than the time getting to the specialist themselves. So we need to get the patient to the right person to get the care that they need, and that is through the emergency department at the same place as the specialist that are providing the care. That helps eliminate 12-hour breaches because the care will be faster apart from the specialist delivering it, and there'll be shorter hospital stays because any lengthy delays in the emergency department leads to longer hospital stays. Ring-fence plan care capacity supports the needs of all of our population. It means that fewer procedures are cancelled. We've seen over the last year or so how many procedures are cancelled because of the pressures on the emergency services. The patients coming through my department take up the vast majority of the emergency beds, and therefore we can't provide the elective surgery that we need to do. This leads to improved cancer waiting times, and it's resilient to peaks in the emergency demand. We know my service in emergency medicine is very predictable, but there are definite peaks. So in the winter, we know that we're going to have difficulties, and elective care is hit by that. So we can protect this and make sure that we can operate on patients who require it all the way through the year. This improves care for everybody in a modern, well-designed healthcare facility, better experience for patients and for the staff as well. And finally, and this is absolutely key, this isn't just about bricks and mortar and a new building. It's about integrating our services through the hospital and out into the community, working closely with our primary care colleagues and in the communities. We can't do this on our own, and the hospital transformation programme is more than just the new buildings. It's how we work together to deliver healthcare across the entire patch for our population. So why is this the right thing to do? I think this is a really key diagram. Currently, our patient flows are very muddled because if you go into the RSH site, you may need to be sent across to an assessment area in the PRH site or backwards and forwards. And that's really key. I'll give an example of this when we talk about children's in a bit. But there's multiple patient pathways, and that requires many ambulances as well. If somebody arrives with symptoms of a stroke, for example, at the Royal Shrewsbury site currently, we have to wait for an ambulance transfer to go over to Telford. And likewise, a patient presenting with abdominal pain at Telford, we have to wait for an ambulance to transfer them across to the Royal Shrewsbury. And that adds delays, and it's a really quite complicated pathway. With all the specialists on one site and the planned care at the opposite side, the pathways become much more simple. It means that we can deliver the care faster, more effectively and safer for our patients. Okay, next slide, please. Again, this is, as I said, this is important. Again, it's a whole service approach. So medicine, urgent and emergency care are together. Surgery, anaesthetics and cancer services are together. Women and children's services and clinical support services. Those four things are linked slightly separately. And moving forward, as Julia will talk about in a minute, there will be focus groups on our work streams. But these are the work streams that we're currently looking at to deliver the care across both fully functioning hospitals. There will still continue to be support services at both sites. Because they're fully functioning, thriving hospitals, they still need all the facilities from pathology, pharmacy, radiology, therapies, catering, portering, housekeeping, security, and IT and digital, because they're still two fully functioning, thriving hospitals. Outpatient outreach services continues at both sites as well, and within the community. We want as many people to be treated as close to their homes as we possibly can do, and our clinical pathways are designed to do that, whilst ensuring that we get the right care in the right place as quickly as we can. One of the questions that we're asked most happens is, what is urgent care? What do I need urgent care? What if I need emergency care? And where do I go? So if I need urgent care, and that's the vast majority of patients that come through our emergency departments, you will continue to go to your local hospital, be it Shrewsbury or Telford. If the problem's urgent, but there's no threat to life or limb, 24-hour services will be available at both sites with the A&E local model, the Enhanced Urgent Treatment Centre. You'll be triaged in 15 minutes, have direct access to the multidisciplinary team, and therefore the diagnosis and treatment will be in the same place on the same day. NHS 111 are quite key to this, and NHS 111 will help you direct to the correct facility that you need to. So as I say, if you go to either site, you will be treated and looked after, and if you can be discharged on the same day, you will be. If you need to be referred to a further hospital, again, that will be sorted, and we will be arranging transport for that. If somebody comes into Telford with chest pain, and we do a heart tracing and it shows they're having a heart attack, as of now, that will be seen, sorted, and you'll be referred over to Stoke. So you'd still be in an ambulance driving over to UH&M, to our cardiac services over there. So the services are set up that if you're, as many people can be treated as close to home as possibly can do. Okay, next slide, please. So why is this an improved service? As I said, most people who currently attend the emergency departments don't need emergency care, they need urgent care for non-life or limb threatening conditions. And the vast majority go home on the same day. So this is an improved service because we can ring fence it, we can get these patients seen far more quickly, the waits will be less, and we'll be able to get them through our systems far faster. At the moment, because we're concentrating on 2 sites with poorer staffing levels, we add delays, and because we're blocked because of the emergency flows, we're blocked and it all backs up into the emergency department. So this is the far greater service we've been providing at both sites. About 2/3 of patients will access urgent care in the same place that they do now through these models at the A&E local model in Telford and the enhanced urgent care service. So you'll be seeing far faster. In an emergency, in a life or limb threatening emergency, you'll be taken to the Royal Shrewsbury Hospital. So there's been a blue light ambulance, 999, you'll be taken to the emergency department to have faster treatment and better treatment with a specialist on site all together at one place. If you're involved in a major trauma, you will still go to Stoke. If you're having a heart attack diagnosed by the very skilled paramedics, you will still go to Stoke or Wolverhampton. So with some of our most significantly ill patients in the county, they already travel very large distances to get to the right care. And it's very clearly shown that the time taken to get to the right place is far offset by having the faster access to the specialists providing that care. And that's the model that we are having here, that the care you will be getting will be safer. This is an improvement and an upgrade in emergency services for the whole of our county. So specialist hospital teams often have to work together. So if I'm involved in a trauma, I have multiple specialists working with me. I'm there as the emergency medicine consultant leading my team, but having everybody on site. We'll come to children in a minute. If a child is knocked off his bike outside Princess Royal Hospital at the moment in Telford, he'll be taken in an ambulance over to Royal Shrewsbury because that's where our trauma unit is, because that's where the surgeons are who I need as part of my trauma team. So a child who is injured in Telford is taken over to Shrewsbury. If he doesn't need to have any acute life-threatening surgery at that place, he's then transferred back to Telford. And this is a very complicated system that doesn't work particularly well, and it doesn't provide the best care. So by bringing all the emergency specialist teams together under one roof, we solve many of the problems that affect issues within our county. Having a appropriately sized, staffed and well-designed emergency department supported by all the medical and surgical specialties means that we can provide rapid care for those that need it. And that's what I want to, as an emergency medicine physician, that's what I want to deliver. And that's why I've come back to the county. Okay, next slide, please.
Thank you. So emergency care, very, very important, but actually an urgent care. But an awful lot of the care we need is not emergency, and it's not the classic urgency and daycare. If we think about what's happened over COVID and the pandemic, so many patients who were due operations, so many patients who were due medical treatment weren't getting it, or they were getting dates for appointments getting cancelled, rescheduled, cancelled, and the number of the surgical patients who got cancelled on the day of surgery is just phenomenal. And it still happens when the hospitals get overloaded with the pressure from all of the emergencies coming on the day. And actually, not just what we're planning here, but being planned nationally, is can we have elective care centres? It's a planned operations. They may still be urgent. They may be done with very rapidity from the time of someone getting symptoms. But what we want to make sure is it does happen when needed and not getting caught up with all of the other pressures. So most patients do not come to the emergency department. They don't come to the urgent care treatment. They attend the different departments for care, all the diagnostics, the x-rays, the ultrasounds, the blood tests, the outpatient care, the day case surgery, the day case procedures. And the emergency, particularly complex immediate surgery, particularly out of hours, yes, that's done and is planned for the Shrewsbury site. But all of this will serve both large areas of North and South Shropshire and the Telford and Wrekin area, but actually a lot of the Shrewsbury patients and Mid Wales patients will come over to the Princess Royal site. for the treatment. And actually, we're going to, as mentioned earlier, start having some of the cancer therapy there as well, the chemotherapy. And for all of those people who've been waiting for the operation or the medical procedure or the care and getting it cancelled and delayed, this will make a huge difference with shorter wait times, fewer cancellations, a much better experience and better recovery. And again, focusing on the care as close to home as possible. Just because you've had that day case procedure or that operation or that planned care at the Princess Royal doesn't mean you can't go to your nearest hospital, your nearest facility for all of those appointments before and after the physiotherapy and what follows. Next slide, please. So we'll have dedicated beds and wards for surgery and same-day treatment, dramatically reducing the risk of no bed available. We're wanting to ensure that operations and procedures take place all year round, not just getting the summer where things are better, with the winter pressures knocking out the care and pushing the waiting list back up. So it's dedicated theatre, dedicated wards, reducing the cancellations, shorter waiting times, faster access, and really important, a recurring thing, is the right staff, the right equipment, the right facilities. So it's the right staff at the right time in the right place, and getting that joined up care so that the specialties that link together will be on the same side. We've all heard of people talking about general surgery. General surgery has stopped existing. We're all specialists now, and it's really important that I do what I'm good at. The next surgeon does what they're good at, and we're not trying to cross over and cover when what you really need is a specialist to provide it. Makes it safer also if you're having your surgery or your cancer treatment away from the infections, away from the medical illnesses. And it's a better experience. There's no question at all about that. If things happen on time, the way it's planned, you can organise your life around it. Next slide, please. Now, it's really important that the services for the women and children is actually delivered with appropriate access to the spread of care that's needed and the very important intensive care and critical care services when needed. But we should note that all of what comes in the antenatal and the postnatal services will continue at both sites. And we do have a problem currently, and I know, Ed, you can tell us about paediatrics and what can happen.
Yeah, so with paediatrics, with children, it depends on what the kids. So the children's unit at the moment is at Telford, but the children's trauma unit is at Shrewsbury, with no inpatient beds in the at the Royal Shrewsbury site. For that reason, we don't have any children's emergency medicine consultants in the county, because these experts want to work in a unit that can provide all the care for children, which we just don't have in the county at the moment. We had one for a year, but she moved out. We have doctors who live in the county but commute out to New Cross in Wolverhampton, or over to Stoke, as I did for a few years, because they can deliver the care that we think is right for the children that we look after. So by bringing all of this under one roof, we'll have a children's emergency area, which is dedicated for all the children within Mid Wales, Shrewsbury and Telford, and we can deliver the care with specially trained children's emergency consultants. The consultants at the moment are dual trained, so I was trained in children's and adults, as are my colleagues. But what we want to recruit are children's emergency medicine consultants. It's a specialist in its own right, and they would really support the care of children that we can deliver in our county.
Thank you. Next slide. Making the most of the investment. Yeah, I think this is a key thing. This is new money. This isn't rediverting money we've got or anything like that. It's not taking away money from other things. This is getting new money in to deliver what the clinicians have got together. We've had the consultation, we've spoken with lots and lots of stakeholders, we've taken advice from the Royal Colleges and other important bodies, we've looked at what NICE advises, and this is a clinically led programme committed to giving the best possible care. We're going to get a lot of money in and we want to use it to best effect. So we now work with architects, we're working with all of the people who can then take our thinking and actually develop it and design it into something that can work. One of the things I've noted that with all of what's going on with Future Fit leading to public consultation to the pandemic, we've had a paralysis of moving forward because everyone's waiting for things to happen. And actually, I think it's really, really important that we move with pace to deliver the best in care we can for all of our community. And I think that's really, really important. And we've got to maximise what we can achieve with how we do things. So, yes, we're getting a lot of money coming in to deliver this part of it, but we're not stopping at that. We will be pushing to get further investment. And I have no doubt in my mind we will be fully utilising both major sites and other sites around the region. And if anything, actually, I suspect there'll be further building and further development. In fact, out with this, we're already got 24 million going into the elective care centre that's being built. For those who've gone past the Princess Royal Hospital, you can see all the building work being done at the front door as that changes as well as we invest in it. And this isn't the end of what we're wanting to develop. This is the start of what we want to develop, and I think that's really, really very important.
So I think it's absolutely key, and the timing is important because with all the delays, with the current financial pressures, it's important that we use the money that we've got now, because as we know, it's become less and less. What the question has been asked, and we'll come to that again in a bit, I'm sure, but with the money that we've got, we are using it to fulfil the clinical model that we set out in the public consultation. And that's absolutely key, that we stick to what we want to do and deliver the best care. And as a clinician, I want to provide the best care for my patients, and that's what this is about. And with the money that we've got, we can deliver that, and that's what we're working towards.
Next slide, please.
So I'm going to hand back to Julia now to talk about how we can get involved our patients and our public moving forward.
Right, thank you very much for that. So this is the important bit for everybody that's sitting there waiting to hear how they can help shape our clinical model, which we'll then describe in our outline business case, which we'll be submitting later this year. We've already mentioned the 4 clinical work streams. Allied to those and aligned to those are the 4 focus groups that we'll be running over months and years as we move towards implementation. The first of the focus groups are taking place in February and March, and I'm already nagging the HTP team to have a full calendar of these throughout the next couple of years, because every couple of months, because we know that when things happen, they happen very quickly. There's the urgent and emergency care and medicine focus group. There's the planned care, surgery, anaesthetics and cancer focus group, the women and children's focus group, and the clinical support services. Now, you may be interested in all 4 focus groups, or you may have a particular interest in just one or 2. We're welcoming everybody that has an interest. We're hoping that we can use your experience, your feedback, your comments to help us develop our outline business case and our services to match what will be the best possible model for you. So if you're interested in attending, please email us. The address is down there, and as I say, it is on our website, and you will get the link through at sath.engagement@nhs.net. As well as joining the focus groups, there are other ways that you can get involved. We have a community cascade every month that we hold on the 2nd Wednesday, and then at 11 o'clock, and then in an evening, and we'll be doing regular updates on HTP on that. We send, if you join us as a community member, you'll get a monthly newsletter update, which again will have updates on HTP in that as well. The focus groups, initially we've booked them for 2 hours each session, and they're going to be on Teams, but we may move to face-to-face meetings as things progress. We just need to get an idea of the numbers because it's being able to manage it, but these will be interactive. They won't be live streamed, as I explained at the beginning. We've had to live stream because we had 164, to be precise, people registered for the event, and it would have just been unmanageable to try to manage that size. But our preferred MO is to have that discussion and debate with you. So those are the 4 groups. That's the email address that you need to use to register for any of those. And if we go to the next slide. So, and as I've already said, there are a range of other ways that you can get involved. This event tonight is not a one-off and then you'll hear nothing from us, you know, for 9 months until we want something from you again. We want to really work with you to make our services the best that we possibly can. Please talk to your colleagues, your friends and family about the programme. Encourage them to get involved. Let us know your thoughts. If you're a member of a group or an organisation and you'd like us to talk to you about what's happening, we'll be delighted to do that. We want you to help us design the services that will better meet local needs. So your perspective is really important. We've involved my team. We've had a number of service changes in recent months. Cardiology has been centralised at Princess Royal temporarily because of the mess that we got into with patients waiting in beds at Shrewsbury to go over to the cardiac cath lab at Telford for days, if not weeks. And that's made a huge improvement. But we involved the community in helping us to shape that. We did the same with the renal dialysis move from the Princess Royal site to Hollingswood House, and with breast screening, and the feedback helped to make those services the best that we possibly could for the people that are going to use them. So we'll also be visiting seldom heard groups because not everybody, and we have a dedicated social inclusion facilitator that goes out and about around the county. So we'll be reaching out to rural and urban communities to hear their views as well. So contact us about becoming a community member using the sath engagement address. Join us at any of our monthly events, and they're on our public participation page on our website, and there will be more up-to-date information coming out on our hospital transformation pages as well. But if you become a community member, and this is a hard sell now, we'll send it to you. You won't have to keep looking at the website because we will be reminding you relentlessly. So that's really the programme. We have got dates for February and March. We may, depending on the response that we get, we may need to put others on, but those dates are fixed. So please do register if you with the focus group that you're interested in, and do visit our sath engagement pages on the website, or email us if you want to hear more about how you can get involved.
Julia, I think it's also worth just adding that we're working really closely with our integrated care system colleagues, because they've got a programme of engagement on the longer term plans across the health and care system. So whilst absolutely we want to continue to focus on the hospital's transformation work, then actually as we've described before, this is whilst an important part, certainly from our perspective, it's only one part of the wider programme of improvement and pathways, as Ed and Richard have described, that we're working on together: general practice, our community teams, local authority teams, voluntary sector and others. So whilst we have absolutely got some dedicated focus groups and events as we've described, we're also absolutely part and parcel, and we'll work together and are doing with our wider system colleagues as well.
Absolutely. And for me, I think that's one of the big differences, Nigel. In the past, it often felt that Future Fit was a bit in isolation, and the community's quite rightly said, well, yes, but how is this going to work with community hospitals? How is this going to work with primary care? How is this going to work with community services? And I think, it is a much more integrated approach. Some of the slides mention that. And I was at an event with Ed with the at the Community Health Council, where they were talking about the ophthalmic services that are currently being engaged upon, and that is by the ICS, even though it's a service that we kind of provide. So that absolute integration between all of the organisations to make the pathways as simple and as clear as we can for patients is so important. Now, this is the part of the About Health event where normally I would hand over to our members for them to ask their questions. As I've explained, because of the sheer number, we weren't able to do that. But this is unusual. We don't normally live stream, and for the focus groups and for Community Cascade and for all the other things that we do, we would adopt the more interactive approach. But we did ask for people to let us have any questions. Hopefully some of them will have already been addressed by the presentation. I was sort of ticking them off in my head as we went through them. We had 12 people that sent in questions, and some of them sent in more than one, but they kind of grouped into these main topics. So what I will do is read you the question, and then if you can answer it. And as I said at the very beginning, we will be writing to the individuals that sent the question to give them their own specific answer rather than this sort of more generic answer, and we will be putting the specific questions and answers onto our HTP website. So I'm going to have to put my glasses on because, as Granny said, old age doesn't come alone. And the first question is, did we consider building one big hospital in the middle of the county or thereabouts? And if we did, why isn't that an option that's going forward?
I can answer that. Yes, it was considered. It was back in when we had the public consultation and the long list and the short list. It was one of the options that was looked at early on, to see actually, is it better to have one central hospital or separate hospitals? And the correct decision was that we should have two separate hospitals, and there's good reasons for that. Partly it's financial. The cost of putting in a brand new hospital in between the two sites would have been vast, and in the economic situation we find ourselves, wouldn't have been feasible. But more importantly to me is the clinical argument. And the clinical argument is that we can separate our planned care and our urgent and emergency care into two separate sites. And that means that we can continue with the planned care services throughout the year, and it won't be impeded by the emergency peaks and troughs of care that we have in our emergency site. And this has been spoken at a national level with the colleges and with the national leads of urgent and emergency care. And it's the model that is favoured for delivering the best for planned care and also for emergency care as well. So yeah, it was thought about, and the decision we've made is to actually, the clinical model that we want provides the best care for as many patients as we can, for all of our patients within Mid Wales and Shropshire. So yes, it was thought about, and the decision made that actually two sites of two thriving hospitals, we're not favouring one there, two thriving hospitals delivering different services but providing the best care for our population.
I think the only bit I would add, and again, Ed talked about it a bit earlier, is that a wide range of services, antenatal, postnatal, diagnostics and others, will absolutely still be able to be provided using both of our sites for the vast majority of the population, which would then be as close as possible. And that also includes the urgent care services with, as we've said, the A&E local model, the enhancements that are planned for our Telford site. So I think it is important we looked at the different options, but I think we absolutely focused on the delivery across the health system for which we support. And actually, when we looked at COVID and the issues again that Richard reiterated, then all that did was reinforce the fact that that's the correct decision. And if we look across the UK and abroad, then that model is continued to be reinforced.
Yeah, I think COVID crystallised a lot of issues for a lot of a lot of operations. Now, this is kind of the flip side to that question, because the first question is, why didn't you just go with one big one? This question is saying, why is one A&E going to be better than the current two that we have? Will that have an impact on travel times and ambulance delays?
So the reason that one is better than two is our current services don't provide the full services. Our current hospitals don't provide the full services at both hospitals. So there's no general surgery at Princess Royal, and there's no inpatient children's or maternity services at Telford, and that hinders time to care, and that makes the care means that we can improve care for all of our patients by getting them, as I said earlier, into the right place to see the right physicians and the right surgeons as quickly as we can do to get the best care that we can. So the one site means that we can streamline the care. It may take slightly longer to get to that site, but it'll be far faster and far safer to get the care that you require. So it is not just about travel time, it's about time to definitive care that's really important for the outcomes for our patients. The other thing is staffing. We can put our senior staff together at the emergency site for our sickest patients. At the moment, we're spread across 2 sites, delivering services that aren't ideal, and that means that we can't have the senior decision makers on the shop floor for as long as we want to do it. By putting it all together on one site, and that's not just emergency in the emergency medicine service, that's also in critical care as well, and acute medicine. So the services where we are split across 2 sites, we don't have as much staff as we want to because we can't deliver the best care, and therefore we can't attract the best consultants and junior doctors that we want to have within our trust.
I think the only bit I would add is that our A&Es, and as Ed has described, currently provide both urgent and emergency care. And as Ed has described, the majority of patients that arrive at our A&Es need urgent care. So we will still have urgent care facilities on both sites, providing the bulk of the care, the urgent care treatment that people need, and that's really important.
We'll actually have enhanced urgent care on both sites, so it's not the same as some other cities have, where they have an urgent treatment centre, which is not what we're going to have. We're going to have something a lot more, with access to the right advice, the right support, the right specialists, the right diagnostics, much more than the urgent treatment centres you get in lots of other places. And there'll be the specialists, the multidisciplinary team will have the right clinicians in the right places to provide the care. So the clinicians will be trained and providing the care that is required for the patients that are at both sites.
And I think it's really important, isn't it, to say that this is 24/7.
Yeah.
Because I know we've heard some questions from people asking whether the urgent care services will be 24/7, and that's absolutely a commitment that we've heard.
Excellent, thank you. And kind of linked to the emergency care location questions, we've had a question saying, how will I know where to go? Well, I think that's really in connection with, I think people are worried that they'll go in an emergency, they'll be on the wrong site.
I think importantly, for the vast majority of people, they are attending hospital because they've either received a letter to attend or an appointment to attend, or they've contacted the ambulance service, they've contacted 111, they've contacted their GPs. They will be signposted to the right place. I think equally importantly, we've got to make sure that in the period between now and as we develop all these clinical models, we should be working with all of our people within the community, everyone, to make sure this works right, that we get the right pathways, we get it functioning, and so it becomes more straightforward, much more simple, and less of a concern, because I do understand this concern that people have. So we're going to have to do a lot of work with talking, discussing, and understanding what people need and responding to those needs. We know what we want to do. What we've got to work out in a lot more detail is the how we will do it. And linked to that, I know that a question that keeps coming up when we discuss this is, what if I don't have the transport? Well, we're looking at into transport. We're looking into car parking. There's lots and lots of other things we're looking into, because we've got the outline, as referred earlier. It's a strategic outline case. We're moving to an outline business case. What we're now starting to work at is getting the detail that helps make it all work. And that's so important. We do it with you.
Yeah, absolutely. And this is why these things are so important, that how we develop over the next few years is doing it with our patients, and we engage and we listen to all the patients, because the patients are the ones that are using our services and they see things that we don't. And that's why the engagement is absolutely key. The other important thing to add is, if somebody comes into a site and they need to have care in a different facility, be it over in Royal Shrewsbury or in Stoke or in New Cross, depending on what the service is, that we will have pathways set up to make sure that they get to the correct treatment swiftly to get the best care. So whichever site they want to, the care will be better and will be directed to the right place. So patients don't need to worry, because we wouldn't be setting, as a clinician, I wouldn't be setting up a service that is less safe and more risky than it is at the moment, because I want to deliver the best care that we can for my patients.
We wouldn't support it, and if we need to, we're considering all sorts of options: express shuttle buses, transport cars, patient transport vehicles. Actually, do we run our own ambulance shuttle between the two sites? There's lots of things for us to be thinking about and working through. What we've got to do is to get it right, is so all of our community, because we serve the community, we work with the community, our community work inside our hospitals. We want it to work for all, that they get the right care, the right time, in the right place, by the right people.
Excellent. And I think the other thing to perhaps reassure this isn't going to happen overnight. And Jenny, as Chief Comms Officer, there will be a lot of communication when we're able to actually implement and deliver the model, so that we'll make sure people are very clear a long time in advance of what it will look like.
Absolutely, and that's one of the reasons why we want to continue to hold focus groups and the whole range of events over the next couple of years, because we want to hear from people. How can we raise awareness of what we're doing? What are people's experiences currently, and how can that help shape the plans that we're working on? And absolutely, how do we ensure that by 2026 that people are fully aware of where they need to go? And that does include our partner services like NHS 111, who can book into time slots into departments, and it's sometimes actually even having that direct access into services. And I think that's something we're absolutely exploring as well.
That they do that now. And as I say, I think, as Richard and Ed have said, there's a huge amount of mechanisms in place which we will continue to use, and obviously we'll continue to work very closely with them.
Now, I noticed the next step slide has come up, but it's only going to take me a couple of minutes to do that. So I would like to ask one other question that has come up. One of the questions we got was about how it's being funded, and I know, Richard, you spoke to that and sort of covered that question off. But the other one is, why is it important that women and children's services have to be on the same site as the emergency site?
I think the key here is the care is not in isolation. Everyone is specialised to get the right care, the specialised care people need. But sometimes you do need more than one specialty. You need the right people at the time you need it. And that's where a huge amount of work has gone into what we call clinical adjacencies. Which bits need to be close to each other, so you don't end up in one hospital needing the services in the opposite hospital when you most need it, and there's not the time to actually start bringing people together, especially if that other service at night is busy doing something in the other hospital. So if something suddenly happens, particularly following an emergency cesarean section, following problems that can happen during delivery, there is emergency general surgeon, as we still refer to it, but that's both the colorectal, the lower bowel surgeon, the upper abdominal surgeon. There's the other specialties that are needed, the intensive care unit with a high level care that is needed. So it's getting the right things together, and it's women's and children's. It's actually also having for all the children, the right linkages. So as Ed described earlier, what we don't want is children attending one hospital where then they need to be admitted, they're being moved to a different hospital, and we don't have the right people in the right places. The other thing we are struggling with, and we'll be open, we struggle to recruit staff, and we struggle to keep staff. Why? Because we're not as attractive for training for the people developing in the specialties as other places, because we've got to be just as modern as they are in our approaches, delivering that top level care as other places are, that we can attract people and hold on to our people. And I think it's really sad when we think of just how great an area Shropshire is for living in, that, as Ed referred to, staff are travelling out with our area to work in the other hospitals. I would so much rather they actually stayed and worked locally, serving our local community. So we've got to get it right that people want to come and work here, want to provide the care here, and of course we get the right care that our communities deserve.
And I would add to that from a training point of view, because our services are split. So we can't have specialist trainees in emergency medicine at the Princess Royal site because it's not a trauma unit and we don't have surgeons on site there. And critical care struggles to recruit as well because intensive care consultants want to work on the sickest patients because that's what they're trained to do. And some of the sickest patients are surgical patients who have vascular problems with their arteries and things like that. So they don't want to come and work at sites where they don't have that specialist the specialist patients to see. So therefore it's harder to recruit. And maternity and the women's services really do need to have critical care alongside them for when things go wrong. So this is why they all come together. So it is partly recruitment, it's partly training, but it's unifying all our teams together.
I do understand the concerns though, because am I going to get, worse outcomes because of travelling and the delay that might happen? Well, it's getting the whole flow of the care right, the whole sequence of care. And we know since we set up trauma networks across England and now Wales are also getting the trauma networks, survival and better outcomes for trauma has dramatically improved. We know that as we set up the vascular centres for the aneurysm surgery, the survival and better outcomes has dramatically improved because people are getting to the right place at the right time with the right people getting the right care. So it is better, it is safer care. And I'll reiterate again, I won't, Ed won't, and I know our clinicians won't. We won't advocate changing to something that doesn't deliver better care. That's what we are focused on, is we want better care.
And can I ask just one very quick question, then I promise I'll go to the last slide. And Nigel, you might be able to help with this one. One of the myths that have been out there is that we're going to mothball the Women and Children Centre, which is a beautiful centre. Can you confirm that isn't the case?
That's absolutely incorrect. I think what Ed was talking about is the objective here is 2 thriving hospital sites, and for me that means making the very best use of the clinical services, the clinical departments that we've got across both sites. So absolutely, we've got a significant investment, and we know that that's about expanding the capacity, making sure we've got some really fit for purpose environments across both sites. But we're absolutely using all of the space that we've got at the Shrewsbury site, and absolutely using all the space that we've got at the Telford site, the Princess Royal site.
Perfect, thank you very much. And if we now go to the next slide with 2 minutes to spare. So, as I said at the very beginning, the meeting has been live streamed due to the large numbers, and we will make it available with the presentation on our website, along with the specific questions and answers, in addition to the generic ones that we've just addressed. Again, a shameless plug for becoming a community member. There are many benefits and no drawbacks, so it will keep you updated. You'll be able to find out about the focus groups, and I think we're at a really important stage in the journey hospital transformation programme. The consultation was completed, the clinical model has been agreed, and we are now wanting input from our communities to help us make that clinical model work to the best that it can to meet your needs. So and if you have any further questions at all on the HTP programme itself, then the email address is there. So I would like to thank the panel for their perfect timing, and well done. Having watched Ed do this twice, I was worried that we would get through it in time, but thank you all for keeping the time. Thank you for the information. I mean, I've been involved in this, but I've learned things tonight as well, so I'm hoping that our audience will have done as well. I really hope that people will take the opportunity to get involved, and it can be the whole spectrum of involvement, from just receiving information to actually being involved in focus group and helping to shape the plan. I would like to thank the remaining 83 attendees that have stayed with us throughout the programme, the presentation, and I hope you found it helpful. If there's anything that you think we should have covered that we haven't, then please email us and we'll make sure that in future iterations of this, because I mean, this presentation has literally changed hourly, and it doesn't bear any recognition to the one that we did last week. So please let us have your feedback, your comments, any suggestions on how we can improve it. And on that note, I will wish you all a good night and a very happy Tuesday. Thank you.
Thank you.
Thank you very much.
Thank you very much. Thank you.